Good afternoon, colleagues, and thank you for joining us for this webinar titled A Simple Cure, HIV Testing and Treatment in the Age of Direct-Acting Antivirals. I am Dr. Shanti Singh Anthony, Knowledge Coordinator for the Pan-Caribbean Partnership Against HIV and AIDS PANCAP, based in Georgetown, Guyana. On behalf of PANCAP Director, Mr. Derek Springer, let me extend a very warm welcome to you. This is our first webinar for 2020, and so I take the opportunity to wish you a happy, productive, and peaceful 2020. A few housekeeping notes before we proceed. Firstly, our mics are muted, so if you have any questions, I ask that you type these in as the webinar progresses. We will take your questions during the question and answer segment after the presentation. Secondly, we're recording this webinar and will share the recording on PANCAP's website for the benefit of the partnership. Finally, you will receive in your emails a post-webinar evaluation. I encourage you to complete and share your thoughts and impressions. This will be useful for us to enhance future webinar experiences. This afternoon, Dr. Nick Walsh will be presenting on hepatitis C. Dr. Walsh is a medical doctor with qualifications through the Royal Australian College of Physicians and with a clinical background in the screening, care, and treatment of hepatitis, in particular hepatitis B and C, and also in HIV. He also has experience in addiction medicine, infectious diseases, emergency and internal medicine, and has worked extensively in Indigenous communities in Northern Australia. Dr. Walsh holds a PhD in epidemiology from Monash University. He has a public health background with particular experience in HIV and viral hepatitis in the Asia Pacific and Australia. He is consulted with the World Health Organization 2006 and has worked in public health and clinical medicine in Vietnam in 2002 and in Cambodia from 2008 to 2014. In 2014, Dr. Walsh became the focal point for viral hepatitis at the WHO Regional Office for Western Pacific and in the Philippines. In the early 2017s, Dr. Walsh moved to PAHO as the Regional Advisor for Viral Hepatitis for the 52 countries and territories across the Americas and the Caribbean, where he continues to support countries in the region to work towards the goal of elimination of hepatitis as a public health problem by 2030. Dr. Walsh, therefore, this afternoon brings to this webinar significant technical expertise and knowledge. I hand you over to Dr. Walsh.
Excellent. Thank you very much, Shanti. It's a pleasure to be here, conducting the webinars on hepatitis. We've given over the past year or so. This one is really important. I'm just going to move this so you can see the full screen, because I'm going to talk today about hepatitis C testing and treatment in the context of direct-acting antivirals. These drugs came to market in 2015 after being discovered, coming from the laboratory in the late 2000s. They initially came to market at $100,000 per course, but have come down remarkably over the last 5 years to be essentially affordable. It's a true revolution. We can cure hepatitis in virtually 100% of cases now. So my presentation today is about how we can translate this revolution, in this therapeutic revolution, into public health action through scaling up testing and treatment in the context of the Caribbean. The message in the work that we do at PAHO and in the World Health Organization is that we take a public health approach to infectious disease. Hepatitis viruses B and C, D as well, cause liver cancer. 80% of liver cancer worldwide is due to hepatitis viruses, hepatitis C, in fact, is the most common cause of liver cancer in our region, viral cause of liver cancer in our region. So essentially, what we're doing by preventing, diagnosing, and treating, curing hepatitis C is liver cancer prevention. The ideal scenario to tackle any infectious disease, any disease, is essentially curative treatment and a highly effective vaccine. Both of these would be cheap and safe. For hepatitis C, we have combination DAAs, direct-acting antivirals, which cure greater than 95% of cases. Real world data suggests it could be 98%. In more complicated cases, the cure rate does go down to the low 90s, but this is a very high cure rate. Unfortunately, we don't have a vaccine for hepatitis C for a variety of different reasons. The most, essentially, the reason we don't have a vaccine is that hepatitis C is an RNA virus, and RNA viruses are subject to mutation rates which are high. For example, HIV is an RNA virus, so any vaccine is quickly mutated around. Nevertheless, we have a variety of different interventions that can prevent the transmission of hepatitis C. This includes infection prevention and control, safe injections, this is medical injections and injection drug use, using sterile syringes, blood screening, safe sex, and harm reduction activities. Of course, these all vary in expense and safety. So that's where we are with regards to hepatitis prevention and treatment at this point in the ideal world. I'm going to move to hepatitis C epidemiology now. We estimate that there are approximately 71 million infections worldwide. 71 million people infected with the virus. Now, this is different to the antibody because there's a proportion of people between 15 and 45% of individuals that will clear the virus spontaneously even after acute infection. So when we talk about 71 million people infected, we're talking about 71 million chronically infected individuals. This is 71 million viremic individuals. You can see the higher prevalence in the Middle East and North Africa, Egypt being the key country there, over to Pakistan. There is a higher prevalence in Europe, Central Asia, Russia, and in Africa. We have a lower prevalence. Every year, there's around 1.75 million new infections. The most common cause of, let's take a look at these 71 million chronic infection. The vast majority came from medical transmission, transfusion, transmission in the 20th century. In terms of the new infections, a large proportion do come from injection drug use, but we still have a number of, or not a small proportion, a relatively significant proportion that are transmitted through medical unsafe healthcare procedures and medical injections. In the Americas, we estimate 5.6 million people are living with hepatitis C. These are new estimates at the end of 2018. The majority of these infections are in those individuals middle age and above. So let's say around 45 plus, and in key populations. Key populations includes all those HIV key populations, but also prisoners. It's a high prevalence in prison. In 2015, we estimate about 65,000 new infections annually in the Americas. Very difficult to estimate the number of new infections in the Americas, well, globally, because it's very hard to detect. Most infections are acute. Most acute infections are asymptomatic, so people don't present for testing. So it's very difficult to track the actual number of new infections. Serendipity, really, and our estimates are from mathematical modeling. We estimate there's around 90,000 deaths from hepatitis C annually in the Americas. That is several hundred each day. In America, in Latin America and the Caribbean, we estimate that there's around 3 million people living with hepatitis C. Now, the majority of those individuals are in Latin America. The Caribbean itself does not have a large number of hepatitis C infections. Most people who are infected with viral hepatitis in the Caribbean will have a hep B infection. So you get a higher prevalence of hep B than for hep C. But remember, we don't have curative treatment for hepatitis B. And with a low prevalence, we could easily eliminate hepatitis C in the Caribbean. Hepatitis deaths by region are presented on this slide. What's notable is that the vast majority of deaths are from hepatitis B and C. B does include D. The other thing of note is that in most regions, hepatitis B deaths outrank hepatitis C deaths, but in the Americas, we have more deaths from hepatitis C than from hepatitis B. Here's a cascade of cure for HCV infection by WHO region in 2017. Now, this is changing dramatically, of course, as countries scale up testing and treatment. You can see that we've got around 75 or 71, about 70 million people infected by region in the different colors. You can see the American region of Americas in the dark yellow. But we've only diagnosed around 15%, or at least in 2017, numbers have gone up a little. And only a very small proportion have been started on treatment, a similar proportion have been cured. By 2017, we estimated that there'd been 2.1 million individuals treated in that year, with a cumulative number of people treated with DAAs around 5 million. So that was at the end of 17. We have another year on top of that. So we're going to be closer to 7 million now. In the Americas, the vast majority of people treated for hep C have been treated in North America. We estimate in last year that probably just over 1% of the population infected with hepatitis C in Latin America and the Caribbean were treated for hepatitis C and cured. One of the key issues, as I mentioned at the very beginning with hepatitis C, is the high cost of these medications. So when it came to market, as I mentioned, curative treatment was about $100,000 per person. Now that was in the United States. It's certainly come down in price, remarkably so. The lowest price globally for a cure is $40 per person. In India, some countries of South Asia. In the Americas, generic combination therapy for hepatitis C cure, which is sofosbuvir declarator, I'll go into that more in detail in a moment, is $130 per person, available through the Parho Strategic Fund. Unfortunately, in the Americas, we're subject to fairly tight patent rules and regulations. Most countries have signed up for the international patent laws, and we do have a number of high middle income countries and high income countries, which means that the generic access is really only limited to about 10 to 13 countries of the region. Now, there are some countries in the Caribbean that do have access to generics at 130, but most countries do not, unfortunately. The price for non-generic hepatitis C cure is around $3,500 per person. Going into the cascade of care in Latin America and the Caribbean, this is cascade of care in 2017. As I mentioned previously, we've only in 2016 we treated around 1% of individuals infected with the virus. we had diagnosed around 20% of people who were estimated to be living with the virus at that time. Now, one of the things, obviously, we don't test and treat people just to get rid of a virus. We do it to improve quality of life. We do it to avoid serious liver disease, and we do it to avoid liver cancer and prevent deaths. The cirrhosis is a much overlooked condition, but a chronic hepatitis C infection results in chronic inflammation of the liver and the development of an increasing amount of scar tissue in the liver, resulting in ultimately a loss of function. Once you get to this functional loss, which is essentially a lack of capacity to manufacture albumin, some of the coagulation factors, to process food proteins, particularly that are absorbed through the digestive system, you reach a state of cirrhosis. We estimate that the risk of cirrhosis at 20 years following hepatitis C infection is around 15 to 20%. That means if I get infected as a 20-year-old, well, if 100 people get affected as 20-year-olds, when those individuals are 40, around 20% will have cirrhosis, and the risk of cirrhosis will increase over time. As I mentioned, the cure is not just about getting rid of a virus, but it does reduce the risk of developing these conditions. The reason is because essentially you're taking an irritant which is resulting in cellular damage out of the system. So you are avoiding essentially that multi-step heterogeneous genetic process that is the development of. You can see here that the odds ratio following SVR of developing hepatocellular carcinoma versus no treatment is 0.2. So you really are looking at an 80% reduction in the risk of carcinoma. You're looking at almost 90% reduction in liver-related mortality, and overall mortality is also reduced by around 75%. So there's significant benefit to cure, which is why we need to test people at risk of any risk of infection and get treatment to these individuals ASAP. WHO first developed guidance for the treatment of hepatitis using DAAs in 2014. At the time, there were only 2. It was monotherapy, it's not much good. We're really essentially in the sort of generation 2.5 now. We updated these guidance in 16, also in 17, because the velocity of change in the market was so great that we really had to do it all over again a year later, from 2016 to 17. We have not needed to update our guidance since, and our recommendation currently is that WHO recommends offering treatment to all individuals diagnosed with hepatitis C infection who are 12 years of age or older, irrespective of disease stage. So this is a treat all recommendation because the benefits of treatment are felt across all of the stages of liver disease. We do recommend pan-genotypic DAAs because there are 6 genotypes of hepatitis C infection. Previously, the early DAAs and obviously interferon had different efficacies in the context of different genotype infections. Our recommendations for pan-genotypic DAAs, achieving high rates of cure irrespective of the genotype of hepatitis. Or let's see, here we go. In terms of the duration of hepatitis C treatment, it really does depend on the combination used. We currently recommend sofosbuvir, well, there are 3 different combinations: sofosbuvir, velpatasvir, sofosbuvir, decladisvir, and glecaprevir, preventosvir. These 3 combinations are essentially made by 3 different companies. Sofosbuvir, velpatasvir, let's call that Sofvel, is a single pill manufactured by one single company. It is recommended to be used for 12 weeks in the context of cirrhosis and non-cirrhotics. And we do have some generic access globally, but alas, we do not have generic access here in the Americas. Sofosbuvir, decladisvir is 2 different pills. It's 2 different companies. Take the medicine together, 12 weeks in non-cirrhotics. For cirrhotics, 12 weeks except in genotype 3. So if you're cirrhotic and you only have access to soft-DAC, then you do need to do some genotyping. It does depend on the prevalence of genotype 3. Genotype 3 is not so common in our region. The most common genotype, about 75% of cases, up to 80–90%, genotype 1. So soft-DAC, 12 weeks in most genotypes, in cirrhotics, in non-cirrhotics, all genotypes, 12 weeks. We do have generic product in the region, $130 per person, and that's manufactured by a company, Mylan, from India. It's imported. Glecaprevir, preventosvir, is manufactured. It's a single pill manufactured by one company. It, in fact, is only 8 weeks of treatment for non-cirrhotics, 12 weeks for cirrhotics in our guidance, and though there are some reductions in this in the latest update, for the FDA update. Unfortunately, this medication remains non-generic. It's extremely expensive. You're looking at $10,000 to, well, $5,000 plus, depending on the country, can be tens of thousands of dollars per person. We don't actually have access to this in this PAHO strategic fund. We have in the strategic fund only sofosbuvir, velpatasvir originator product, sofosbuvir, decladisvir originator and generic product. Nevertheless, glecaprevir, preventosvir is an important drug because, unfortunately, sofosbuvir is unable to be used in individuals with stage 4 or 5 chronic kidney disease, which means that if you have a glomerular filtration rate less than 30, sofosbuvir is contraindicated. So therefore, you would have to use glecaprevir, preventosvir in this particular group. So that was one of the reasons why it is, in addition to being a pan-genotypic, in our guidance. So, what's the assessment for hepatitis C treatment? We recommend in our WHO guidelines for the testing of hepatitis B and C, just a single serological assay for hepatitis C. This is an antibody, hepatitis C antibody, can be an antigen, that meets the minimum safety, quality, and performance standards. There are a number of WHO pre-qualified rapid tests and platform-based tests that do the job. We have several available in the PAHO Strategic Fund. The price of a rapid test of adequate performance standard for hepatitis C antibody is $1 per test through the PAHO Strategic Fund. So it's very affordable. As I mentioned at the beginning, hepatitis C is an infection that in 15 to 45% of individuals will be cleared spontaneously. Now, this depends on a variety of different factors. It depends on the extent of the exposure. It depends on the frequency of the exposure. Obviously, higher frequency exposures will result in a greater likelihood the individual will be viremic. And so in order to confirm that an individual does have the infection, is viremic, as opposed to just being exposed and having spontaneously cleared. We need to confirm this viremia with a qualitative or quantitative nucleic acid test for the detection of RNA, hepatitis C RNA. We also do another RNA test at the end of treatment, 12 weeks after the end of treatment, to confirm cure. This is called a sustained virological response 12, or SVR12. So when an individual, to be diagnosed, an individual will need one antibody positive, a confirmation RNA PCR, positive or negative. Negative, of course, you don't have the infection. But if you're positive, candidate for treatment, treat 12 weeks later, you confirm the cure with a SVR12 RNA. There is an additional test that is coming to market, which is called hepatitis C core antigen, which does have a comparable clinical sensitivity to NAT. In areas or countries where there's a high prevalence of infection, it's essentially very cheap, but in low prevalence countries, it's not recommended because it can be expensive if the volume is low. Clinical assessment, of course, is essential. You need a history of physical examination, looking particularly for the presence of stigmata of chronic liver disease, hepatomegaly, splenomegaly. We also do recommend an alcohol intake assessment. As we're all aware, chronic alcohol dependency can result in damage to the liver, and so we do need to screen individuals for alcohol using an audit, which is AUDIT, the audit screening tool. We estimate that about 15% of the mortality associated with hepatitis C in the region is attributable to alcohol. So it's an important screening. It's important to screen for alcohol. We've, in our guidelines, reduced the number of tests that are recommended because we want to be realistic. We want to reduce costs, and we felt that a number of the tests that had been recommended previously, or at least the frequency, was unnecessary given the safety of these new drugs. Full blood count, of course, is important, looking for the hemoglobin and platelets. Low platelets can be a result of cirrhosis. You really do need to do that at the end of treatment as well. Liver function tests, of course, ALT, AST, ALP, total bilirubin. We use the APRI score, which is here. You can get this online. It's the ratio of the AST to the platelet count. So if you get the AST and the platelet count, you can calculate an APRI score, and you can really, it's exclusionary for cirrhosis. So individuals with a low APRI score, very unlikely to have cirrhosis. Higher APRI score can have cirrhosis. So you really don't need to do liver biopsies. You really don't necessarily need to do the FibroScan looking for cirrhosis. If you do these biochemical marker calculations, the most common being the APRI score. So we strongly recommend that clinicians calculate the APRI score. We also recommend that laboratories report the APRI score when reporting results of a full blood count liver function test associated with the testing of hepatitis C. We would say that the reporting of an APRI score from laboratories should be essentially mandatory in the context of liver disease. Liver synthetic function, of course, important in cirrhosis. You know, this is really differentiating between decompensated cirrhosis and compensated cirrhosis, the INR, the albumin. As I mentioned, an RNA PCR or the core antigen, depending on what you have available in the Caribbean, it's going to be an RNA. APRI score, as I mentioned, and that's essentially it. So you really have a very few tests. These tests are widely available, apart from the hepatitis C RNA. I wanted to just mention on the subject of RNA testing for hepatitis C that these are obviously platform-based tests, but GenExpert and other multiplex platforms do have cartridges for hepatitis C. So, for example, if your country or clinic does have a TB or an HIV GenExpert machine or other multiplex platform, the hepatitis C cartridge can be used on those platforms. We understand that in many places, the TB program, for example, or the HIV program, for example, will have purchased the machine. So there will be a process of negotiation to be able to get access to those machines for hepatitis C cartridge use. But you know, we're in an era of trying to make the most of the resources available. We don't have squillions of dollars, particularly not in hepatitis C. So we would advocate that countries do look at utilizing multiplex platforms such as GenExpert and incorporating hepatitis C cartridges in those platforms. The Partner Strategic Fund has those cartridges available for most countries in the Caribbean for around $15 each, so relatively cheap. So what are some clinical scenarios that we need to be aware of in the treatment of hepatitis C? As I mentioned, these are very safe drugs, very few side effects, cure almost 100% of cases. Sounds almost too good to be true, but we do have to be cognizant in a number of different clinical situations. HIV co-infection, HIV hepatitis C co-infection, important. The studies do show that the cure rate in Hep C HIV co-infection is exactly the same as mono-infection. So this is something that's very different to the interferon era. You're really looking at cure in the high 90s, or at least in the 90s% range in co-infection. So we really need to screen everyone with HIV for hepatitis C, cure them of the Hep C, because in countries who have had antiretroviral programs for some time, Hep C is an increasing cause of HIV-related mortality. In fact, in some places, it is the leading cause of HIV mortality, hepatitis C infection. So curing Hep C infection in the context of HIV co-infection is very important. There are some drug-drug interactions that we need to consider, but they're very few and far between. I would refer you to the technical guidance on the specifics of these. Just to mention that we do not have to, well, we need to always check, but the risk of co-infection, or the risk of drug-drug interactions is relatively low. Hepatitis B, hepatitis C co-infection, another important co-infection, not so common, does occur. The key risk in Hep B, hepatitis C co-infection, is that a proportion of individuals who are infected with hepatitis B will reactivate during and following hepatitis C treatment. So the idea is that in Hep B, Hep C co-infection, one virus will become dominant. Once you remove the Hep C infection, that will allow the Hep B virus to once again become dominant, which will result in a flare, and people can get quite unwell. So if you're Hep B surface antigen positive, well, firstly, everyone with Hep C needs to be screened for hepatitis B before Hep C treatment. But if you're Hep B surface antigen positive, you really do need to consider whether this individual does need to be covered with tenofovir or entecavir during or prior to Hep C treatment to avoid hepatitis B reactivation. It doesn't happen in everyone, but we need to be cognizant of this. Cirrhosis, of course, is difficult to manage in some cases. A higher SVR can be achieved in individuals with cirrhosis, compensated cirrhosis. Decompensated cirrhosis, a little more difficult, does require specialist input, which does lead me to mention that non-cirrhotics can really be managed at the primary care level. So cirrhosis specialist involvement, shared care at least, F0 to F3 non-cirrhotic individuals can be managed at the primary care level. But of course, if you have cirrhosis, your risk of hepatocellular carcinoma is elevated. Individuals without cirrhosis tend not to get hepatocellular carcinoma, but the risk of hepatocellular carcinoma does increase with cirrhosis, and particularly with decompensated cirrhosis. So we do need to screen individuals 6 monthly for Hep C, with cirrhosis from Hep C for hepatocellular carcinoma, and this is done with an ultrasound examination and of the liver and an alpha feta protein. We do recommend that individuals with decompensated cirrhosis in particular do have an endoscopy to exclude varices, which also increase mortality. But we're talking about the very severe end of liver disease here. Chronic kidney disease, chronic renal failure. As I mentioned, sofosbuvir is contraindicated in individuals with severe renal impairment, GFR less than 30 mils per minute. So it's always important to do a creatinine, calculate a GFR in an individual that is going to be a candidate for hepatitis C treatment. Glecaprevir, preventosvir is effective against all the various genotypes, pangenotypic, and is not contraindicated. So in that case, you can use this other medication. There are a couple of other drugs combinations that are effective, are safe in the context of stage 4-5 renal failure. I would consult our guidance on that. Elbazir, graziopravir is one combination. There's another combination which is called Vicurapac. So if there is no access to glecaprevir, preventosvir, GP we call it, then you can look for some other combinations of other medications that are available on the market. In terms of TB, in people with TB, HCV, co-infection, treatment for active TB is considered before the treatment of hepatitis C infection. Again, reactivation can occur, but particularly some of the drugs that are used in the management of tuberculosis, some of the anti-tuberculosis medications, do result in a risk of liver damage, and so we do need to be cognizant of the drug-drug interactions because of this increased risk of hepatotoxicity. Retreatment after DAA failure. Well, we're not curing 100% of cases. There are always cases that are not cured for a variety of different reasons. There are some mutations. Occasionally, adherence in some cases. This is an area of fairly extensive work at this point in time to try and understand why those few cases do not get cured. But at this stage, we only have one pangenotypic DAA regimen that is recommended in the context of retreatment or after DAA failure. This is in our guidance: sofosbuvir, velpatasvir, voxilaprevir. So that SVV combination is effective in curing 98% of individuals who failed treatment. So essentially, if you have access to first and second line therapy, you're really curing 99.9% of individuals with hepatitis C. Fortunately, this drug is expensive. We don't currently have it in the PAHO Strategic Fund. There's very little demand. And there are some schools of thought that if you do fail, for example, Sovel, that you could try another combination. But you know, this is fairly technical and would require a specialist consultation. So if you failed treatment, we would recommend a hepatologist consultation. So I was asked to just add in a little bit about hepatitis C, HIV co-infection. we have been advocating for screening for hepatitis C, hepatitis B in the context of HIV infection for a while now in WHO. And now we have the opportunity to treat. If you look at these two graphs, this is the prevalence on the left of HIV infection among those people with hepatitis B and C infection. So we only have a very few, this is globally, only a very small proportion of the total number of people living with hepatitis B and C are in fact infected with HCV. But on the right, if you look at the proportion of people that with HIV infection, there is a not insubstantial number of people living with hepatitis C and hepatitis B. So the recommendation here is that we screen all individuals with HIV for hepatitis B and for hepatitis C infection. Of course, antiretroviral therapy does contain Hep B active medications, so tenofovir, lamivudine, FTC, all effective against hepatitis B. And now we have curative Hep C treatment. So we strongly recommend implementing this policy at the national level. For a number of years, we have been trying to link indicators from HIV to Hep C and Hep B, and the reverse, of course. We had consolidated HIV strategic information guidance in 2015, having two indicators, proportion of people in HIV care tested Hep B and the proportion of people in HIV care tested Hep C. And the treat-all recommendation in 2016, proportion of people who have been started on ART who have been tested for Hep B or Hep C. And then, of course, in 2016 and thereafter, we had our treatment coverage indicators, to which we added on coverage of hepatitis B, HIV co-infection, infected persons on tenofovir-based therapy, and those with Hep C HIV co-infection who were started on DAAs. So we're really capturing data now in the Global AIDS reporting system, also the Global Hepatitis reporting system. So that data shows on the left Hep B. I will just briefly talk about Hep B. The proportion of people starting ARV therapy who are tested for hepatitis B, so we're talking on the left here, by WHO region. See that the region of the Americas, roughly about 60% of people tested, or in 2018, were tested for Hep B of those who had started antiretroviral antiretroviral HIV therapy, and in if we look at hepatitis C on the right, unfortunately it is below, at least in 2018, below 50%. Our simplified testing and management algorithm is here, a little hard to visualize, but it's in our guidance on the web. As I mentioned before, just to run through it very quickly, a single rapid test for the antibody detection screening test, reflexive hepatitis C RNA to confirm or exclude infection, assessment of liver disease and the clinical assessment. So this includes the APRI score, treating everyone who's positive for RNA or viremic with a pan-genotypic DAA, and then a test of cure at 12 weeks post-treatment SVR12. So relatively straightforward. So what do we do? How do we operationalize this relatively straightforward guidance at the level of at the country level, at the national level? How do we really operationalize a public health response to hepatitis C? We recommend strongly that countries have a comprehensive national plan for the elimination of hepatitis C, Caribbean countries have a low prevalence, so easily can be eliminated if sufficient numbers of individuals are tested. And this means focusing on those people who are at risk, have had any exposure, or are in an age cohort. Simple and standardized algorithms across the continuum of care. This is what I've illustrated today. Integration of Hep testing, care and treatment with other services, particularly with HIV services. Strategies to strengthen linkage from testing to care, treatment and prevention, of course. Decentralization of the response. This includes task shifting. So a number of countries now are initiating testing, or have nurse-initiated testing and nurse-initiated treatment because it is more resource efficient. And as I mentioned, if you're non-cirrhotic, you can easily be treated by a primary healthcare provider. It's very simple treatment. Community engagement, peer support to address stigma and discrimination, or reach vulnerable or disadvantaged communities. Effective and efficient procurement and supply management of medicines and diagnostics, and data systems, the latest and most important being the Global Hepatitis Reporting System, to monitor the quality of individual care and cascade of care. So the Global Hepatitis Reporting System is rolled out now. All countries in the Caribbean have access to the portal to enter data of on the cascade, and some of the policy indicators. We strongly recommend this. The system is still open for 2018 or 2018 data. So please enter the data as soon as possible. So we take specific public health approaches in 5 key population groups. These are population groups that experience high incidence or prevalence, stigma and discrimination, criminalization or special vulnerability. This is individuals who inject drugs, people in prison or other college settings, men who have sex with men. The incidence of a transmission is higher in this particular group, particularly in HIV positive, MSM, sex workers, and Indigenous populations. So if we implemented a public health level, we can see that we do have an impact. This is data presented from Australia. Australia in 2015 started to roll out DAAs, focused on the cirrhotic population. Initially, it was an expanded treat everyone 2017. And they've now treated over 60% of individuals with cirrhosis living hepatitis C. And you can see the number of, in the dots, the observed diagnosis of cirrhosis. Predicted mean is the mean diagnosis, predicted mean diagnosis, solid line. And if there had been no rollout of DAAs in Australia, the predicted diagnosis mean would have increased as such in the graph on the left. But what's happened in reality, the dots, is that you had quite a marked downturn in cirrhosis diagnosis. You also saw a flattening of the HCV liver cancer diagnosis rate, which was on its way up, in fact. And we have actually seen a reduction in mortality, substantial reduction in mortality, compare as to in terms of the increasing rate of deaths, which we had seen in that country relating to hepatitis C infection. There's really been a substantial downturn in mortality. In fact, the mortality impact is a 20% reduction in the first 3 years of the program initiating. So that's really remarkable. We think about hepatitis C being a chronic infection. It doesn't really matter what happens, in the first, 20 years of infection. Clinicians have long been relatively uninterested in getting on top of Hep C infection quickly, waiting until later in the stage of the disease. But we can see data, at least at the population level in Australia, indicates that if you introduce a public health approach to tackling hepatitis C and an elimination program, essentially you can get marked impact at the population level very quickly. So that's all from me today. Thank you very much for your time. It's a pleasure, as always, to connect with our colleagues from the Caribbean. We're available at any time to take questions online now, of course, or by email, and we are at your disposition as a resource to improve the public health response and the quality of care, hepatitis C infection and management in the Caribbean. Thank you very much.
Thank you so very much, Dr. Nick Walsh, and thank you for the collaboration with PAHO WHO. I think that was a really pretty comprehensive presentation in terms of hepatitis C virus. Clearly, hepatitis C remains a significant global public health issue with 71 million people infected, new infections, almost close to 2 million new infections occurring annually. Latin America and the Caribbean obviously is not spared, 3 million people living with hepatitis C. I think the good news is that, as you shared, Dr. Walsh, there is treatment, and what's even better, I think, the cure rates with that treatment is really high, greater than 95%. The issue, though, is that it still remains a significant public health issue because to date, we only have about 7 million people globally that has been on treatment. Generic combinations are available that I think is excellent, and the fact that treatment prices have gone down significantly from when we started earlier of about $100,000 US per year to about $130 per person to treat hepatitis C. I think, just to recap some of the clinical pieces that you've shared, we need to be mindful that some of the medications are contraindicated in persons who have kidney disease, stage 4 and stage 5 kidney disease, and that we need to be really mindful and pay close attention to persons with hepatitis B and hepatitis C co-infection because of the risk of hepatitis B reactivation. And in those instances, we need to make sure that we manage the hepatitis B with tenofovir. Certainly, as you've said, there have been a few cases of treatment failure, and in those instances, the need to have retreatment with an even stronger pangenotypic regimen. I think in terms of hepatitis B and hepatitis C, co-infection with HIV, that too is significant. And so the recommendation that's coming out is that all persons diagnosed with HIV should be screened for hepatitis B and hepatitis C. And I know that in many of our guidelines in the Caribbean, we do have hepatitis B and hepatitis C screening for people living with HIV. Thank you so much for sharing some of the operational steps, some of the steps to operationalize a response to hepatitis C. And so what I wanted to ask is a question in terms of hepatitis C screening. You would know, Dr. Walsh, that the Caribbean has several countries in the Caribbean, in fact, have really embarked in a very serious way on PrEP programs. So we've started PrEP programs in the private sector. There's PrEP that's going on in some civil society organizations, and we've been advocating to use PrEP programs to really screen for other sexually transmitted infections. Can you say whether or not hepatitis C is on the panel of tests for STI screening based on WHO recommendation?
Thanks very much, Shanti. I mean, so the way I would answer that is that yes, essentially, if you have any risk factor for hepatitis C, and remember that in individuals, men who have sex with men, that is a risk factor for sexual transmission of Hep C, particularly in the context of HIV infection or exposure. We do recommend Hep C screening. We also recommend Hep C screening in age cohorts 45 plus, depending on the country. Obviously individuals who've had any exposure to injection drug use, any contact with the prison system. So if there is any risk factor for Hep C acquisition, then we would recommend hepatitis C screening. Now, in terms of the populations accessing PrEP, we find a lot of commonality. So certainly individuals starting PrEP should be screened for Hep C.
Okay, thank you very much. And just one point of clarification, I know that you said that generic treatment is available for, I think it was $90 to some of the Caribbean countries, and that was coming from Mylan. Is it $90 US per patient, or is it per month?
So there are a few countries that do have access to generic preparations in the Caribbean under their patent laws. I won't go through the individual countries now because it is a little complicated, but the price is $130 per person for 12 weeks with sofosbuvir declarasphere. So it is a total price for the full course per person, $130 US.
Okay. Okay, great, thank you. I don't see any other questions, Dr. Walsh. So this really brings us to the end of the webinar, and I want to again express our appreciation and thanks to you, Dr. Walsh, for presenting today and presenting on hepatitis B late last year. Thank you very much, and thanks for the collaboration and the support from PAHO. Thank you, colleagues, for joining us and for participating in this webinar. I do trust that you would have gained new knowledge that will be useful in your work. I will, as I always do, share the PowerPoint presentation in an email to you shortly. Just as a gentle reminder, the webinar was recorded and will be shared on PANCAP website. Please also complete the post-webinar evaluation. We again will highly appreciate your feedback. And join us for our next webinar. The announcement will be sent out to you shortly. Finally, in closing, I encourage you to stay engaged with the regional response. Look out for new and upcoming webinar research articles that will be posted on PANCAP social media platforms, Facebook, Twitter, and do continue to stay engaged with the regional response. Again, thank you all for participating, and have a good afternoon.